This movie presents an investigation of the structure and function of the gastrointestinal system using endoscopic videos and histological samples. The distinct structures of the esophagus, stomach, small intestine, and large intestine will be investigated at the anatomical and cellular level, providing a comprehensive overview of this complex system. The alimentary canal is a continuous tube of varying diameter that extends from the proximal part of the esophagus to the distal part of the anal canal. At the cellular level, each functionally distinct section of this tube contains a mucosa, submucosa, muscularis externa, and a serosa or adventitial layer, and variations in each of these layers contributes to the organ's function. The following video is an upper endoscopy showing the spectrum of the normal anatomical findings of the upper alimentary canal. As the procedure begins, the tongue is shown in the upper portion of the screen, and the endoscope is passed through the oral cavity. As the scope passes the epiglottis, it approaches the dividing point between the trachea and the esophagus. Here, a clear view of the trachea, vocal cords, and upper esophageal sphincter can be seen. The upper esophageal sphincter consists of skeletal muscle and is controlled by the swallowing center located in the brainstem via the vagus nerve. This sphincter opens during a swallow, allowing the bolus of food to enter the esophagus. The scope passes through the upper esophageal sphincter and into the upper esophagus, showing a clear view of its morphology. The esophagus is a fixed muscular tube that delivers food and liquid from the pharynx to the stomach. Over most of its length, the esophagus is adventitial to other structures as it lies posterior to the trachea and anterior to the spinal column. As the esophagus passes through the diaphragm and into the peritoneal cavity, it obtains a serosa, which consists of a layer of simple squamous epithelium called mesothelium and a small amount of underlying connective tissue. Histological section of the esophagus shows its distinct layers. Under low magnification, the mucosa, submucosa, and the two layers of the muscularis externa can be distinguished. Between these two layers is a thin connective tissue layer within which lies the arbux plexus. The muscularis externa is unique in that there is a gradual transition from primarily skeletal muscle in the upper esophagus to smooth muscle in the lower esophagus. Histological section of the muscularis externa of the middle region shows the interwoven smooth and skeletal muscle fibers. A closer look at the esophageal mucosa shows a stratified squamous non-keratinized epithelium. The lamina propria contains cardiac glands in the distal esophagus. The muscularis mucosae varies in thickness down the length of the esophagus and is composed of a single layer of longitudinal smooth muscle. Esophageal glands proper are located in the submucosa throughout the length of the esophagus. Their function is to secrete a mucus solution, which can be seen as the white, foamy substance that lubricates the walls of the esophagus. As the scope passes down the length of the esophagus, the lower esophageal sphincter can be seen. The epithelial transition from the smooth, stratified squamous epithelium of the esophagus to the simple columnar epithelium of the cardiac stomach can be seen. Histological section of this junction shows this distinct transition. Also note the esophageal cardiac glands located in the lamina propria, which function to secrete a mucus solution that protects the esophageal mucosa from the acidic contents of the stomach. Here is a closer look at this transition. After passing through the lower esophageal sphincter, a clear view of the gastric morphology can be seen. Upon gross observation, a thin film of mucus covers the gastric mucosa to protect the underlying tissue from the high hydrochloric acid content. Gastric folds called rugae are also seen, which disappear upon distension of the stomach. Anatomically, the stomach is divided into four regions: the cardia, the fundus, the body, and the pylorus. However, histologically, the stomach is divided into the cardiac, the fundic, and the pyloric regions based on the type of gland seen in the gastric mucosa. Histological section of the fundic region shows its distinct layers. The gastric mucosa, which we investigate in more depth shortly, consists of a simple columnar epithelium composed primarily of surface mucous cells. The submucosa is composed of a dense, irregular connective tissue, and the muscularis externa is composed of 3 layers of smooth muscle: an incomplete neurooblique layer, a thick middle circular layer, and an outer longitudinal layer. As stated before, the gastric mucosa consists of a simple columnar epithelium. Invaginations of this epithelium are known as gastric pits. The lamina propria is made up of loose connective tissue and houses the gastric glands, while the muscularis mucosae is composed of a poorly defined inner circular layer and an outer longitudinal layer. The most prominent glands in the gastric mucosa are the fundic glands, which are shown here. These simple branched tubular glands in the lamina propria consist of an isthmus, which connects the gastric pit to the gland. However, it is often difficult to distinguish on H&E preparations. The gland itself consists of the neck and fundus region. The isthmus is the site of the regenerative cells that replace all of the epithelial cells of the gland, gastric pit, and luminal surface. At the base of the gland, the basophilic chief cell is apparent and is responsible for secreting pepsinogen, a precursor to the enzyme pepsin. The eosinophilic parietal cell is also apparent and can be seen throughout the length of the gland. This cell is responsible for secreting hydrochloric acid and gastric intrinsic factor, which is required for vitamin B12 absorption in the ileum. As shown here, the gastric pits are lined primarily by surface mucous cells. Mucous cells below the isthmus and in the neck region of the gland are called mucous neck cells. Diffuse neuroendocrine system cells are also in the neck region of the cell, but are difficult to distinguish in H&E preparations. This illustration summarizes the 2 main types of glands seen in the gastric mucosa. On the left are the glands of the cardiac and pyloric regions, whose primary function is mucus secretion. The glands on the right show the fundic glands, which are the most prominent glands in the stomach. As the scope progresses towards the pyloric region of the stomach, slow peristaltic contractions can be seen. These contractions function to churn gastric contents in preparation for entrance into the duodenum. The gastroenterologist now turns the scope around for a retroflex view of the cardiac and fundic stomach, an important routine procedure used to check for gastric ulcers and other pathological disruptions to gastric epithelium. During this peristaltic contraction of the pyloric region, the gastric pits can be distinguished. This is known as the pit pattern, which will also be seen in the colon. Here is a clear view of the pyloric sphincter, the entrance into the duodenum. Here the muscularis externa transitions back to its typical bilayered structure. The sphincter itself is an anatomical thickening of the inner circular layer and is the dividing point between the stomach and the small intestine. The small intestine is approximately 7 meters long and consists of 3 regions: the duodenum, the jejunum, and the ileum. The duodenum is the most proximal portion and is about 25 centimeters long. The jejunum is about 2.5 meters long and constitutes the upper 2/5 of the small intestine. The ileum is approximately 3.5 meters long and ends at the ileocecal junction, or the entrance into the large intestine. There are 3 specialized modifications that work to increase the surface area of the small intestine. These include villi, microvilli, and plica circularis. Intestinal villi are finger-like projections that extend about a millimeter from the mucosal surface into the lumen. The villus structure of the intestinal mucosa contributes to the velvety appearance seen at this magnification. Plica circularis, also known as valves of Kirkring, are permanent circular folds that contain a core of submucosa and can be seen here. They are most numerous in the distal part of the duodenum and the beginning of the jejunum and begin to disappear in the ileum. On the surface of the villi are microvilli, which provide the major amplification of the luminal surface and make up the striated border. These modifications collectively increase the surface area of the small intestine mucosa by a factor of 4 to 600. Upon histological section of this junction, the distinct layers and cellular organization can be investigated in more depth. At low magnification, the mucosa, submucosa, and muscularis externa can be distinguished. The muscularis externa consists of an outer longitudinal layer and a thickened inner circular layer, which makes up the pyloric sphincter. Gut-associated lymphoid tissue is also seen at this transition. Brunner's glands are also apparent, which are structures unique to the duodenum. A closer look at the epithelial junction shows a distinct transition from the presence of surface mucous cells in the gastric epithelium to a predominance of goblet cells and enterocytes in the intestinal epithelium. Also notice the transition from the presence of gastric pits to the presence of villi and intestinal glands. As the scope re-enters the duodenum, another clear look at the villous structure of the intestinal mucosa can be seen. Histological section of the duodenum shows its distinct organization. At low magnification, the layers can be easily distinguished. Between the two muscular layers lies the myenteric nerve plexus, otherwise known as the Auerbach's plexus. The submucosa consists of a dense irregular connective tissue with blood and lymph vessels along with Meissner's plexus. Brunner's glands, which are only seen in the duodenum, secrete a bicarbonate-rich solution with a high pH that neutralizes the acidic chyme as it enters the duodenum. These secretions also bring the intestinal contents to the optimal pH for pancreatic enzymes. A closer look at the intestinal mucosa shows individual finger-like villi, shown here. The core of these villi consists of lamina propria, which contains cells of the immune system, fenestrated capillaries, and blind-ended lymphatic capillaries called the central lacteal. These lymphatic vessels are responsible for transporting dietary fats in the form of chylomicrons. The two main cell types here are the mucus-producing goblet cell and the enterocyte. Goblet cells are interspersed between the absorptive cells and increase in number down the length of the intestine. The enterocytes are tall, simple columnar absorptive cells with a basally located nucleus. An electron micrograph of the enterocyte shows the microvilli on the apical surface of the cell that makes up the striated border and houses the glycocalyx. The goblet cell is also shown here. The openings between the bases of the villi lead into intestinal glands, known as crypts of Lieberkühn. These crypts are simple tubular structures composed of a simple columnar epithelium that is continuous with the epithelium of the villi. At the base of the intestinal glands are Paneth cells. These cells contain intensely eosinophilic apical granules. These granules contain lysozyme, which digests the cell wall of certain bacteria. Other cells of the small intestine include enteroendocrine cells, intermediate cells, and M cells. Enteroendocrine cells are concentrated at the lower portion of the gland and release hormones, including CCK, to the basally located blood vessels. Intermediate cells are found at the bottom third of the intestinal glands and serve as the precursor cells to the epithelial cells of the intestinal mucosa. Lastly, the M cell is an epithelial cell containing microfolds and basal membrane invaginations that form pits with lymphocytes and antigen-producing cells. Here's one of the few spots where there is a discontinuous basement membrane. The function of the M cell is to transport antigens to the underlying cells that can mount an immune response. These cells are typically found over the Peyer's patches in the ileum. At this point in the upper endoscopy, the scope is located in the jejunum. Though there is no distinct epithelial transition from the duodenum to the jejunum, the location of the scope can be inferred by the high number of plica circulares. A quick look at a transverse section of the jejunum shows the same basic organization, including the mucosa, submucosa, and muscularis externa. Note the absence of the Brunner's gland in the submucosa and the lack of Peyer's patches, which will be seen in the ileum shortly. A closer look at the epithelium shows a slight relative increase in the number of goblet cells in comparison to the duodenum. The following video is a retrograde endoscopy of the distal portion of the small bowel and of the colon. In contrast to the previous video, the scope will be facing opposite the direction of advancement, providing a linear investigation of the lower gastrointestinal tract. The large intestine consists of the cecum, colon, rectum, anal canal, and the appendix. The colon is divided into the ascending, transverse, descending, and sigmoid sections. The scope begins in the distal portion of the jejunum and is pulled back to the ileum. Here, the villous structure of the small intestine can be seen again. A thin film of yellow mucus and bile coats the outer surface of the intestinal mucosa. Here, lymphoid aggregates can be seen and are known as Peyer's patches, which are structures unique to the ileum. Histological section of the ileum shows the lymphoid aggregates located in the lamina propria and extending into the submucosa. A closer look at the epithelium shows a further increase in the relative number of goblet cells when compared to the jejunum and the duodenum. At this point in the procedure, the scope has progressed through the entire length of the large intestine and is in the ileum of the small intestine. A closer look at this boxed region shows the ileum feeding into the cecum of the large intestine. Separating these two structures is the ileocecal valve. Here, the scope has been drawn in to show its current location. In a few moments, the scope will be pulled backwards and will pass back through the ileocecal valve, showing a clear view of the cecum morphology. Here's another view of the ileocecal valve that the scope just passed through. At this junction, there's a distinct epithelial transition from the villous structure of the ileum to the smooth mucosal surface of the colon. The villous pattern and Peyer's patches of the ileum are also faintly visible. Adjacent to the ileocecal valve is the orifice to the appendix. Surrounding this opening are hyperplastic lymphoid follicles. The large intestine functions primarily to absorb fluids and gases, along with vitamin K. It also produces abundant mucus, which lubricates its lining and facilitates the passage of fecal matter. Here, the repeating pattern of pouches and folds can be seen. The pouches are referred to as haustra, while the folds are referred to as plici semilunares. Also notice the colonic mucosa is almost completely transparent, allowing the viewer to see the extensive network of vasculature that nurtures these tissues. As the scope is pulled back through the ascending colon, a faint blue structure appears underneath the colonic mucosa on the left-hand side of the screen. This is the liver. Upon gross observation, the large intestine has a much larger lumen in comparison to the small intestine, and the mucosa lacks villi. A sharp eye will also make out the faint pit pattern, which is also seen in the gastromucosa and represents the many crypts of the colonic mucosa. A cross-section of the large intestine at low magnification shows the mucosa, submucosa, muscularis externa, and the serosa. Although this basic structure is seen throughout the gastrointestinal tract, several key differences should be noted. As stated before, there are no villi in the large intestine. The large intestine also contains tinea coli, which are thick bands of outer longitudinal smooth muscle. 3 tinea coli extend along the length of the large intestine up until the rectum. A closer look at the mucosa shows straight, unbranched tubular glands, again referred to as crypts of Lieberkühn. The cells that line the surface of the glands are principally absorptive cells and goblet cells. The relative number of goblet cells progressively increases towards the distal large intestine. Enteroendocrine cells are also present but are difficult to distinguish in H&E preparations. In the base of the glands are stem cells, which typically have a turnover rate of 5 days. The liquid seen here is a mixture of bile and cleansing solution that the patient is required to consume 24 hours prior to the procedure. At this point in the procedure, the scope has been pulled back through the ascending, transverse, and descending colon, and is now in the sigmoid colon. The colonic mucosa, as seen throughout this procedure, is almost completely translucent, showing a clear view of the vascular plexus. As the scope progresses towards the rectum, also notice the disappearance of the repeating pattern of pouches and folds, and the relative increase in vasculature. The pit pattern can also be clearly seen. Here's a retroflex view of the anal canal, an important routine procedure to check for hemorrhoids and colonic polyps. Here's the last epithelial transition of the gastrointestinal system. Histological section of this region shows a distinct transition from the simple columnar epithelium of the rectum, consisting primarily of goblet cells, to the stratified squamous non-keratinized epithelium of the anus. This is known as the pectinate line. The stratified squamous non-keratinized epithelium soon becomes keratinized, as it is continuous with the exterior skin. Because of its location, the pectinate line is difficult to view on endoscopy. In this final section, common pathologies of the gastrointestinal system will be investigated. These include Barrett's esophagus, gastric antral vascular ectasia, a colon polyp and removal procedure, and a gastric ulcer. Barrett's esophagus is a condition in which the stratified squamous non-keratinized epithelium of the esophagus is replaced with the columnar epithelium. This video shows a typical appearance of the pathological metaplasia of a patient diagnosed with Barrett's esophagus. In the distal esophagus, the normal pearly white esophageal mucosa contrasts the salmon-colored mucosa of the Barrett's esophagus. A biopsy of this region shows the presence of columnar and goblet cells in the esophageal mucosa. Gastric antral vascular ectasia is an uncommon cause of chronic blood loss in the gastrointestinal system. This condition is associated with dilated blood vessels that line the antral gastric mucosa. As shown here, the long streaks of dilated blood vessels in the stomach leads to chronic bleeding and can be the cause of iron deficiency anemia. The cause is somewhat unknown, however it is associated with portal hypertension and chronic liver disease, resulting in abnormal steroid management. Treatment of this disorder involves burning the affected tissue with an argon plasma coagulation unit. This instrument uses the repulsion of ionized gas that conducts a high-frequency electrical current that, when it comes into contact with tissue, results in the coagulation of the bleeding tissues. The result of this treatment is the formation of scar tissue. On the right side of the screen, a sessile colonic polyp can be seen located in the distal colon. A polyp is any protrusion above a mucosal surface and can be pedunculated, or containing a stalk, sessile, or flat. To remove the polyp, an endoscopic snare is used, which is passed through the endoscope. The snare is then placed around the entire polyp. As the wire is pulled back, the snare tightens, severing the entire polyp from the normal colonic mucosa. Pathological section of the polyp shows a tubular adenoma with low-grade dysplasia. Architectural organization shows orderly, closely packed tubes of colonic epithelium. Goblet cells predominate, while the enterocytes display a normal nuclear to cytoplasmic ratio and a basally located nucleus, which are all indications of low-grade dysplasia. Upon examination of the prepyloric region of the stomach during an upper endoscopy, a large gastric ulcer can be seen. An ulcer is defined by any break in the membrane, and in this case the gastric epithelium. As much as 95% of peptic ulcers are associated with Helicobacter pylori, which is a spiral-shaped bacterium native to the acidic environment of the stomach. Ulcers can be worsened by certain drugs such as aspirin, ibuprofen, and other COX-2 inhibitors. This patient had been taking Vioxx, a COX-2 inhibitor, for the treatment of osteoarthritis for several years. Histological section of the peptic ulcer shows a clear break in the gastric epithelium and crater formation. In the advanced stages of the gastric ulcer, 4 pathologic zones can be distinguished. These zones include necrosis, inflammation, granulation tissue, and scar tissue. At this magnification, acute inflammation and ulcer exit can be seen. Acute inflammation includes leukocyte infiltration, while the ulcer exit is seen as the pink fibrin debris seen throughout this section. The non-invasive treatment for this ulcer includes cessation of the COX-2 inhibitor medication and proton pump inhibitors, which work to decrease parietal cell HCl production. After 5 weeks of therapy, the area is completely healed, leaving behind only scar tissue.